Thank you for staying with us on Daybreak. I'm your host, Olive Burrows, and with me in studio, I have Dr. Ruth Libon Marsha, who is the CEO of the National Syndemic Diseases Control Council. We have Professor Walter Joko, an expert in microbiology and tropical diseases. We also have in studio Dr. Victor Bampoe, UN AIDS Country Director, Rita Gatonye, a harm reduction champion, and she'll speak to us about injectables and the harm and how that can be reduced. We also have in studio teen parents Wesley Otieno and Zipporah Achieng, who are also HIV champions. I cut you short, Dr. Marsha, on the work you're doing or that is being undertaken in the counties. We are making progress. You were talking about mother-to-child transmission of HIV. But I just wanted to point out the issue Zipporah raised of stigma. Where we have counties that are marginalized, have very high stigma rates, like Wajir, Mandera, Samburu, West Pokot, Isiolo, the transmission rates are probably some of the highest in the world from mother to child to their babies. For example, in Wajir, where we're saying that in the country the average transmission rate is about 7.3, Wajir has 33.5%. Again, when we look at deaths related to AIDS, you will find that those counties also have some of the highest AIDS-related death rates. It means having HIV in a very stigmatizing situation also kills. So stigma actually does kill, because what is killing is not lack of access to medication. It's that people can't go to the facility because they fear what their neighbors are going to say, or they fear from being discriminated by those who love them. And Wesley just mentioned that the fear of your family rejecting you. And so we had hoped by 2015 we'll be able to reduce mother-to-child transmission of HIV by 5% or less than 5%. So we wanted to achieve that target by 2015. Today, we are 2024. We still are at 7.3%. So for us as a country, we've made progress, yes, but it is not right for any child today to be infected with HIV through father, mother to child transmission, because we know that they can be born without the virus. We know that the medication works. We know that if the mother is tested early, she gets on antiretroviral medicines, her viral suppression is achieved, her child gets prophylaxis at birth, during breastfeeding period, then she is able to prevent the virus from passing to the child. And really giving that child a free start, free HIV status start from a positive mother is actually the best gift any parent gives to a child, any scientific advancement gives to this child, and anything as a country can do. And the only way as citizens we can do that is stop stigmatizing the mothers who are positive. Because if we don't stigmatize them, then they will actually be okay to go to the facility. And we are not talking about even the ones who already know they have status, because those are the best mothers. They actually, those living with HIV, we find them in the facilities. They go early, they check their viral loads even before they plan for their pregnancy, because they are within the care. The challenge is this mother who doesn't know her status. And she's fearing to be tested, and she delays the decision. And we must remember it is common, you know, as people who probably think they are high risk, but they have high levels of self-stigma. They delay going to the hospital. You know, you're pregnant 3 months, 4 months, and sometimes even up to 7 months is when they say, okay, just let's test now. So that is a part we have to look at. Then the other one is people testing with their sexual partners. And we really encourage couples to test, because we've got very high levels of discordancy. And if you go together and one of you is negative, we know that the negative one also can get into pre-exposure prophylaxis and then stay negative. And the positive one gets into ARVs, and that couple can still remain together. The challenge is where then now each one of you assumes the status of the other one. So the positive one may assume that we are all positive. Sometimes it's not the same, the scenario. And we want to encourage people to plan having babies. And part of that plan involves a HIV and syphilis test. it should be part of our normal, the way we say I'm going to school and in these degrees, you're going to have a baby. Our baby needs to be free of these things. And there is science, there's all these people available, facility available. The medication is free currently because it's given to us through either Exchequer funds, or we are currently using funds from donors to buy the drug. So there is no reason why that should happen. So that is what we are trying to champion. And if we do that in the next 5 years, then we can get where Victor talked about us, saying that indeed this disease is no longer a public health problem because we have sorted all these stigma issues. We have normalized people accept that there's a virus. It's a high burden country, because that is what you must realize as a country. It is a high burden country, therefore meaning that the chance of you in Kenya getting an exposure to HIV is higher than where HIV is not an issue in other countries.
All right. Rita, I'm sorry we cut you short earlier, but your sound should be fine now. So, you know, when Dr. Marsha Wex was speaking about stigma, and part of it is people have this notion that, you know, it's an indicator of sexual promiscuity, but that's not just the only way that it happens. There's mother-to-child transmission, and there's also drug users who are at risk. Can you speak to the work that's being done in that space in terms of to reduce, because you're a harm reduction champion, reduce the risk, and also what challenges you encounter?
Okay, thank you, Olive. And again, as Dr. Marsha has said, the issue of stigma is more widespread for women generally. And this is the same in the drug using space, where we have men and women who use drugs, but the stigma is a lot more when you see a woman that's using drugs. And in this case particularly, we're talking about injectable drugs. So, for example, heroin. This already is a substance that's not much spoken about. The issue of drugs is not much understood yet in our society. So there's a lot more stigma towards the women in that case, and this leads them to avoid coming out for services. So this leads to situations like what Dr. is saying, that a pregnant woman who knows she's using drugs will shy off from testing, from even going for clinical services, and then we end up seeing situations of mother-to-child transmission and so on and so forth. The challenges we have, which led to the HIV prevention within people who use drugs, is that people who inject drugs used to share needles. So before the advent of some of these harm reduction programs, people would share injecting needles, and that then led to the risk of transmission of HIV, hepatitis, and then people who use drugs because of the isolation use in isolated spaces. So then you have the risk of transmitting TB and all these other things going on. So that remains a challenge, but we have made progress. So a harm reduction champion, like I was saying, is somebody who champions for the package of services under the harm reduction package, which is needle and service provision, education on overdose management, education on safer drug use, because you can't really tell somebody to stop without having attempted to understand all the reasons behind their use of drugs, psychosocial support, which is very important very important for people who are using drugs. And then, again, issues of ART initiation and hepatitis testing, screening and treatment, then the same for TB. So the challenge we face is that there hasn't been that much focus on people who use drugs, because it is a criminalized population. Because of the criminalization of drug use and drug possession, then it's been a bit challenging to focus on this hidden population. And so new infections may keep popping up now and then because a woman who uses drugs may not be able to walk into a health facility just anywhere because of the fear of stigma, because of the fear of loss of custody of her child, and so on and so forth. So that's the challenge that we're having, but we are actively working with the government and the actors here to move into that space and to see how more gender-sensitive harm reduction services can be availed, and how women who use drugs and their children can be reached by more HIV prevention mechanisms.
All right, and it's interesting that you raise that, because globally the theme is about equal access to healthcare, and then here is a forgotten population that is at risk. Dr. Bampoe, can you speak a little bit on why equal access to healthcare is so critical towards ending HIV/AIDS by 2030?
Thank you very much. I wanted to first go back to something that Dr. Marsha and Prof raised about how, and I think it was an interesting question that you asked about how the fight is going and whether HIV/AIDS has lost its, the fight has come down a little bit. And yes, the challenges are many now. For example, in the health area, we're dealing with non-communicable diseases and things. And so HIV has been going on for quite a while. The danger with it is that we are at the last mile. So if we don't do something about it, it can then explode again. So we really need to focus on it. But as you can imagine, as we get closer and closer to the last mile, it gets more and more difficult. And why does it do so? Because it is getting to populations that are more difficult to access. We talked about stigma and discrimination. What that does is that it pushes people to the margins of society, so it's more difficult to reach them with health care. So it's important that there are two ways to look at the response. The first is the biomedical, and I think both Dr. Marsha and Prof spoke about it. So it's the prevention, the condoms, the pre-exposure prophylaxis, post-exposure so those are the biomedical. But then there's also the softer side, making sure that the people who are most in need of the services actually get the services. So I'll give you one statistic. In East and Southern Africa, every day, about 507 young women and girls between the ages of 15 and 24 acquire HIV. There are countries where we are still not reaching those who need the services. So how do we make sure that these services get to the people who need them? Until and unless we get to the margins of society, the young women, the girls, the young boys and men, the other groups that are at the margins of society, then we're going to have a challenge making sure that we get to the 2030 target. And that is why it is important that rather than relent on the fight against HIV, we actually increase the efforts to make sure that we are able to cut it off completely. And that is why World AIDS Day is an important day for us, and it's been celebrated since 1988. So.
All right. I'll bring you in at this point, Zipporah, because there is the 18 to 24 demographic you're talking about, young women. Zipporah, you're a teen mom, so your cohorts are a vulnerable population. What do you, in your view, is the missing link?
The missing link first is the stigmatization, because if today you're stigmatized by the community, by everywhere we go, you cannot even have the energy to go and access the service. And again, it was said that it is information, but nowadays I think information, because I'm not the only championing for HIV, we are as many, and I'm happy that the government has given out the community champions from the community, like peer champions, mentor mothers. The mentor mothers now are the people like me who had children with the same HIV status, and they are having negative children, whereby they work from the community to the hospital, whereby they refer and they give you the hope, they hold the woman who is living positively to have the chance to have the negative baby. So what was your question?
Do you mind my asking, right? Because part of what Dr. Marsha was talking about earlier was planning of pregnancy, such that if you intend, in your case, you already knew your status. You work with teen moms. Are there teen moms who did not plan their pregnancies, and how did they find having talked to them and interacted with them in those situations?
I will use my experience. I got my child when I was in Form 2, and that was 17 years. It was 2020. So you see, my mom held my hand, but there are some girls who they don't even say, you know, like you cannot just stand up and start telling someone that I'm pregnant. You see the way people will take a look at you like you're HIV positive at the same time pregnant and you're still in school. Why? So when my mom knew that I was pregnant the first day, because she knew when it was one week old, because of how I was behaving. So she took me to the hospital, and since I've been taking treatment from that hospital, so when I was tested and they found out that I was pregnant, my viral load was very high that time because I was in school, boarding school, coming from going to school. You know, when you're in school, it's not a must to take the medicine. You always get a chance when people are outside, but when people are in classes, you don't take. So my viral load was high. So the doctor told me, Zippy, you know, now you are a mother, and again, you have to have this negative baby so that you have to start taking your medicine. And that's how I started. But for some girls whom I work with, it is hard because, first of all, they have not disclosed their status. Maybe when they had pregnancy, now that's where they found out that they were HIV positive. First of all, she doesn't have anyone to go to. She does not talk to any of the parents. So you see it as a burden. When you go to the hospital, first of all, you are a minor. You have to have the parent concept for you to be, like you say, a lot of things. Because you're pregnant, you need someone to escort you to the hospital. Like a 15-year-old girl cannot be accessed without a parent concept. So you see, like, there is a challenge because that disclosure and how people see you and how the society sees you, like, it creates a lot of discrimination that even you cannot withstand it. And some of them says, okay, I'll go to the hospital when I'm due. You haven't had the injections, the injections that people are being given, like the tetanus, the rhesus, everything you don't have. But for me, I will say that my mom held my hand, and that's why I have a negative baby. From this, and plus the support I had from the hospital, the facility. Sometimes you could access the government. When this is not done, you just write a note, say this one was not done, and they will take part in going to the hospital to see whatever it's there and whatever it's not there. For me, I'll say that for my side, I had to put more effort on my side because I had the support.
Yeah, the support system.
Yeah, and that's why I'm giving back to the community the same, because I believe that I'm the only, since 2001, I had many friends and I lost them due to HIV stigmatization. And from there, I gave myself that urge of helping because I don't want to lose anyone anymore due to HIV. Yeah.
All right. Wex, I saw you nodding as Zipporah was speaking. Are there things about her experience that resonated with you?
Yeah. So, kuna hii time watu wanakuona kama yani ufai kwa hiyo mali wako. Yani hiyo kuna mtoi bado uko positive. Kama mimi mabeshte zangu kuspend time nao ilikuwa rahisi. Yani ilikuwa ukienda kuspend time nao wanaanza kutoka. Mara nyingine anasema wewe ufai kuwa na hapa hivi, ni mbuda sahi sasa. Ufai kuwa na vijana sahi hapa hivi kwa mtaa. Unafaa ushughulikie mtoi wako. So ijakuwa rahisi sana. Kwanza hiyo part ya stigma itakuwa rahisi kwangu juu hata shule kuanzia form 1 hapo. Juu mimi na yangu niseme yangu imejulikana ni kwa class 8. From hapo sasa ndo nimeanza ku take medicine, but nadhani ilikuwa nayo juu mamangu na alikufa nayo. So kwanza class 8 ndo imepatikana. Na kwanza hiyo class 8, kwanza class 8 imekuwa mbaya sana juu mabeshte wangu kawa 5 hivi. Niliwaambia niko nayo, wakaniambia wewe ufai kwa hapa sasa, si beshte yetu sasa, tafuta marafiki wengine, hatutakuwa na wewe sasa. Hiyo part ya stigma ijakuwa mzuri sana kwangu. Alafu pia ni kwa form 2 ndo nikagetwa mtoi. Ijakuwa rahisi pia Kwa familia, unajua kwanza familia wa Afrika si rahisi sana kukubali uko na mtu na kwanza tena uko shule. So haijakuwa rahisi sana kwa familia pia. Na pia kwa familia si kila mtu anajua niko positive. Niseme ni watu kama 2 5 ndio anajua niko positive. Hao wengine hawajui. Naogopa pia kuambia, pia watanitenga. So mambo na stigma si rahisi, but tunaendelea mzuri. Tumeishi bado hata kama tumekuwa stigmatized. Yeah.
All right. What do you make of WEX? Just some of the numbers that Dr. Masha was speaking about, because the focus this year, because there's a marathon planned for Sundays, is men and boys. This is a tweet I'm reading from the National Council for Population and Development, just basically what Dr. Masha spoke about. In 2023, new HIV infections peaked at 5,968 in Kenya. 44% were among men and boys. Alarmingly, 9,808 AIDS-related deaths were among men aged 30 plus. A total of 487,710 men and boys are living with HIV. This is a wake-up call to action. So, do you support the focus this year being on men and boys?
Yeah, I focus. Kwanza imekuwa mzuri sana hiyo mambo na marathon. Kwanza ya dizia nadhani itakuwa poa sana. Yeah.
All right. Professor Jaoko, there's something interesting you mentioned. You said women are a more vulnerable population for a number of factors, not just socio-economic, but you also said biological.
Yeah. Yeah, it is biologically it's easier for HIV transmission from a man to a woman than vice versa, for several reasons. First of all, the genital mucosa, the membrane that covers the genital mucosa in women, is much wider than for men. So the chances of a virus using the surfaces to get entry into the body is much more than in men. Social, it's economic. Many women depend on men for economic sustenance, and therefore, if you're in a relationship where the man is HIV positive, you have no way of bargaining for safe sex. Like if you want to use condom, if you tell the man to use a condom and they refuse, there isn't much that you can do. It's the same socioeconomic issues that drive women to commercial sex work. And so female sex workers are trying to survive. And some of the clients insist on not using protection. The women do not have bargaining power. And so there are many factors that make women more at risk of getting HIV.
So having said that, having listened to Dr. Masha and she was running through the numbers, and she said, but when it comes to deaths caused by HIV, or what do you call them? HIV-related cases, right? Mm-hmm. She said it's more or less 50-50. Mm-hmm. Why is that? Is it that men are not getting not accessing healthcare? What is it?
Yeah. So it's known that men and women health-seeking behaviors are very different. Women would seek assistance much earlier. Many of the HIV-infected women know their HIV status before the men. Men are very reluctant. And this is not just for HIV, for many other diseases like high blood pressure, diabetes, chronic illnesses. You find that the women are much more compliant to treatment than the men. So if you look at the figures, like the national HIV prevalence figures is 3.3. But women are double to men. So although the national HIV prevalence is 3.3, meaning that out of 100 people, you're going to get 3 people infected. When you separate it between men and women, you find that the men is 2.2 and the female is 4.4. So it's double. So in terms of the number of people who are infected, the women are more. But then these women are getting treatment, they have a support structure, the men are reluctant, they're not going for treatment, they're not using the ARVs, and therefore when it comes to death, although you'd expect the double, more women, twice the number of women dying than the men, now it balances just because of the health-seeking behaviors. Mm-hmm. And I think this is also something I need to talk about stigma that we've been talking about, because also men are very afraid of stigma. Mm-hmm. And I sit in the HIV and AIDS tribunal which is under the judiciary, the only tribunal of this nature in the world, thanks to the government of Kenya. And you'll be surprised by the number of cases that are brought to the tribunal when people complain about stigmatization, discrimination in job opportunities, in schools. You find schools not willing to accept children who come to Form 1, and the mother tells the headmistress, oh, my daughter is HIV positive, this is the medicine they usually take, can it be given to the matron so that they can be taking on and the woman say, no, the headmistress, we don't admit HIV positive. So this stigma issue, it's still a big concern, and we need to make every effort to fight it. And maybe I'll take this opportunity just to let your viewers know that there is a tribunal. And their offices are at Reinsurance Plaza, and they can go to any court and be advised on how to seek assistance. It's the only court that you can file your case without paying a court filing fee. It's the only court that you'll be provided with a pro bono lawyer. If you don't have to fear that you have no lawyer, you cannot afford it, the government will provide a lawyer for you to fight your case when you're discriminated against because of your HIV status. Okay, and this is for people who've been discriminated against on account of their status? Yes, it is all sorts of HIV issues, like you've been tested without your consent. That is an offense. If you've been discriminated against, if you have been tested without pre-test counseling. So there are many. We have a law. It's called the HIV prevention law in Kenya. It's called HAPCA. Mm-hmm. Yeah. So people need to know that HIV is treated very seriously by the government. Okay. Dr. Masha, there's a half marathon that's going to take place on Sunday, and the focus is men and boys, is my understanding. What is the message you're hoping will come out of this?
So for a long time, just like Professor has said, it's been really assumed in this country that when you say that women and girls are disproportionately affected by HIV, it's not a problem for men and boys. Two things. He talked about biological, but and because of that biological concept, there are studies now where we look at what we call phylogenetic. We follow the virus. And some of those studies have been done in Kenya. And you find one virus from a man was found in about 5 to 7 women average, meaning that the source was the man to about 5 to 7, and which is a concept he was explaining. It is easier for a man to transmit HIV when he has it to the women than the other way. And because of that concept, it's sometimes misunderstood that men don't share the active role of ensuring they get on treatment, they get virus suppressed. And actually, if they all are found and mostly get on treatment, we'll have actually fewer cases among women and girls. Then the other element why I want to spotlight on them is for their own health. Because then men have, for a long time, because of the gender and social construction, they feel strong and they only come to the hospital too late. The damage of AIDS in the body, usually we say it's sometimes irreversible. Because if you come too late, your organs, kidney, liver, most organs that can be replaced are already too damaged. Then you get the virus suppressed, but also those organs become a problem to you, and they give you a chronic disease. So we are telling men also, for your own sake, not only for HIV, please start spotlighting on your own health, access health care, because it is good to have also healthy men and boys. Then the problem of adolescent pregnancies and sexual and gender-based violence. We've been trying to follow cohorts of women and girls who are sexually violated and see how many of them come within 72 hours. And we look at that cascade of they came, we give them post-exposure prophylaxis, we give them emergency contraceptive pill. But out of those, we start looking at how many got HIV. So if we have a cohort, you will find that about 100 cases, 120 cases are found within a very small cohort of about 7,000 women who have come to the facilities. Again, we want to say that let sex be done with consent. And you can't talk to the women about seeking consent. We need to talk to our boys. He told us that his girlfriend is 17. We have far too many cases within even our prisons of boys who have gone to prison because they have impregnated a smaller girl. Sometimes when you talk to them in the juvenile prison, they say, I did not even know she was 9. She looked too big. I don't know when she's 10. So where are we missing the point as parents? What are we telling our children, our boy child, about the law? Does a boy child know that a sexual offense occurs even by him having sex with a minor? So we are leaving those boys behind. I met teen mothers in Kibra who have ran away from Form 2. They were arrested by the police in high schools because they impregnated a girl. And now they are vijana wa mijengo in the slum because of fear of being arrested. But when you look at the case, when they explain to you the age of the girl, he is in Form 2. Now the girl is 17. I don't know how the difference in their ages. You find it's a Romeo and Juliet case. So again, when you go to the law, the judge has to now start thinking, who do I punish here? Is it the girl or the boy? So the numbers of boys having children is also increasing, because in some countries you find it is about older men and younger girls. But in Kenya today, we also have a big problem of teen fathers. And we must now have this marathon and open the discussion where we are saying we cannot hide this anymore. If you go to the maternity, the 241,000 girls I spoke about whose school was interrupted in 2023 because of a pregnancy, and those are the only ones who attended the facility. And out of those, you look again at the children, the small children, 10 to 14. There were 11,379 children, 0 to 14. If you go and find out who the father of the child is, it's another Form 2, Form 3, Form 1 boy. So we are saying that let's not just talk to the girls alone. Don't put the girls alone under the tree. Because when you go to the school and talk to the girls alone, the one they're having sex with is the boy on the other side of the room. So we are saying, bring the boy and the girl, let's talk to them. Tell them there's the law. There's actually consequences of having sex, not just HIV, not only pregnancy. Let's talk about human papilloma virus. And HPV is something you haven't spoken to our children about. We know very well that early sexual debut can get the child with the HPV is prevalent within our country. And we also know that it is also associated with cervical cancer. So we see the cases of cervical cancer increasing. We know chlamydia. Chlamydia is a serious sexually transmitted infection. But you haven't told our children. Only when they become about 24, 25, 26, they're in a relationship, they want a child, and they find their fallopian tubes are blocked. And mostly it's the girls who find themselves infertile. Again, spend their entire life trying to correct the infertility. So we need to be talking to our children and telling them there are more diseases. We have forgotten just because we only spotlight on HIV, even the boy. Syphilis, what does happen to syphilis when it's untreated long-term? Brain damage. So we have to begin the conversation not with the girl but also with the boy. So we decided that this year, the AIDS deaths, the infections in boys, just because we have a high burden, we then think that the boys are not infected. But if you took the number of boys living with HIV in Kenya, you also took the boys and men, and you took the new infections and put them in another country, they will actually be seen too many. Because then you're not comparing with the women within the same country. You're going to be seeing that it's actually a huge epidemic also among men and boys. So we are calling out them for their health, but also for them to be partners in terms of making this social change we want. It's a shift and a drastic one. We don't have money anymore. So we have to use what we have, which is our social connections that we have, from the parent to the child, religious leader. And we are trying to say that, hey guys, we cannot have the same conversation we had in the 80s, in the 90s. She spoke about drug use. In most families today, they are struggling. When their child is injecting heroin, what happens? Of course, it's good to pray about it. But she said that it's impossible. In fact, recently she told us, for a woman, what she felt, the withdrawal symptoms of not having heroin, was a pain of labor pain together, that two, come in, and then you must find where the heroin is for you to inject yourself. And parents are struggling. They don't know there is treatment. They don't know that child can be helped. And then what happens later is a child leaves home and goes to the street. We find them in the den, and we begin to start programs with them. And sometimes even when they are healed, like she can tell you, it was not easy to be accepted back. When they are healed, we try to then take them back to their families. And families say no, because this child started injecting drugs. And to inject drugs, you need money. I think about 2,000 shillings per day. Where do you get 2,000? For a woman, you begin to have sex work. If it's a boy, they begin to steal. They steal your laptops, they steal your phones, they steal literally everything. So the next thing they find themselves is in another conflict with the law, police cell. From police cell, we find them in prison. So after prison, they come back. When they come out, they go back to the den to look for the heroin. And the circle continues. So you have about 26,000 people who are injecting drugs, and 17% of them are women. And those women, again, are starting with a pregnancy in most cases. I got pregnant in Form 2, I got chased away from home, and I found myself, with a partner. The person who introduces, actually about 80% of the women who use drugs, the person who introduces heroin to them is their sexual partner. Boyfriend, husband, is the one who is introducing. Again, look at the role of the men. They're introducing this woman into heroin, they're introducing into these other drug habits, and the impact and the effect of that woman is much, much more severe than it is even for men and boys. So we are having this conversation this year saying that we must also bring men at the center and remind them it's not for women, also for their own health. And that's a concept of promoting the health and well-being of men and boys. Tuberculosis, even without HIV, affects more men in this country than it does women. And we haven't been talking to men about tuberculosis. A lot of men cough, especially if they are men who go out in the evening. So every time they are coughing, when you ask what the problem is, they say, niko na baridi. Na ni homa. And that homa, usually sometimes, is tuberculosis. It may not even have HIV, but they delay the treatment of TB. Until then, again, we are losing more men to TB. When you look at AIDS-related deaths, most AIDS-related deaths occur as a result of TB. And TB, if it was diagnosed early, again, can be treated. But then the men come too late again in that TB clinic. So that's all the things that are connected, the violence against women. You've had how many, even femicide cases we're having, because we haven't begun a really deep conversation. Fathers speaking, even the children have been brought up by single women, they are fathers within the community who can actually speak to the boys. And maybe Wesley can tell us more. What does he find? Is there a man role model who comes to him? Is there any man you have gone to around you, said, Wesley, you're young, you have a child at this age, this is how men and boys should live, and maybe probably why then you have your child with you. So those are some of the concepts we are bringing out this year, that it is something we can win. It's a war we can win in our lifetime, but it cannot win when once our population is actually a major part of the country is being left behind. When we lose those ages of men and men, again, back to the women's story.
All right. So Wesley, before you speak about mentorship and the role, why it's so critical, Dr. Bampoe, given the political commitments you were talking about earlier, by 2025, by 2030, what is UNAIDS encouraging governments to do to leapfrog?
That's a brilliant question. I think Prof. and Dr. Masha talked about the current context and the more or less unpopularity, not unpopularity, but the less prominence of the fight against HIV. It's also affected funding. So we see that funding over the years is gradually declining. UNAIDS and its co-sponsors is urging countries to look at making sure that these gains that we've discussed today are sustained, because it will be a shame to actually lose all the progress that we've made, and especially looking at the complexity that Dr. Masha so eloquently explained. If we let go of the fight against HIV now, it's going to affect other diseases, it's going to affect other things. So one of the main things is, how do we sustain the gains? If funding is going down, how do we ensure that we step up domestic resource mobilization to make sure that we have the funding to fight against the disease. How do we make sure that we have new technologies and, more importantly, people have access to the new technologies, like the long-acting injectables? We're at the stage where we have injectables that can be taken twice a year, and as part of the PrEP or pre-exposure prophylaxis. How do we make sure that more people get this? So these are the short to medium term. In the long term, you see that we're talking about the softer or the enabling issues, because around this is the issue of people having access to information, making sure that they can take the right decisions, education for young women, education for young men. But those are broader issues. So we are urging countries to look at it in terms of the short term, the medium term, and the long term to make sure that we get HIV, AIDS, as not any public health problem by 2030.
All right. Zipporah, there's something you said, and I saw, I'm kidding, Prof. Flinch. You said, you're in high school, Form 2, and, when there are people in class, you are not as comfortable taking the prescribed drugs on account of the stigma that you feared. You still took that decision knowing, speaking of education, knowing that this could increase your viral load, that you could get sicker.
Yeah, because before we are given this medicine, we have support groups in the hospitals. So we are always told, because when we close schools, we always go back to the hospitals during the holidays, where we always meet. Sometimes we talk, we explain about our experiences. And I will say for me, it was the fear of stigmatization, because I was stigmatized since childhood, in school, at home, everywhere. So I took that part because I was telling myself, I was not informed like now. So I was telling myself, if now my friends are gone, and what am I doing here? So I was doing it because of not the fear, but my aim was to die, because that time it was being said that, at least now people are being told that there's injectables, there are drugs, there are mother-to-child transmission. When I was growing up, people knew that you got HIV from sex. Even the teacher will discriminate you, saying that you started sleeping with men at an early age, you see. So I think for me it was the fear, and I knew what I was doing, because I will tell myself, now I'm taking these medicines in front of them, and when tomorrow morning comes, my story will be all over the school, ZP is using drugs, you see. So when I was at home, I will be taking my medicine daily. But in school, it was like today, yes, tomorrow, no. The other day, yes, because it depends on the preps. And again, I couldn't carry the medicines because of the noise they were making. And again, the skirt pocket was small, so it cannot carry, second line, it cannot carry 2 medicines. So, and again, I cannot go back to class when people are learning for me to go and take the medicine. The matron will say that I'm taking myself as a special person. Now you see the challenges that are in high school. Or maybe the matron will tell you, go with the prefect. What are you going to tell the prefect that these medicines are for? Wexley said that he was saying malaria. I had many diseases. Today I was having pneumonia. Tomorrow I was having chest pain. The other day I will say that like all sorts of diseases, for me to cover myself from people knowing of my HIV status. Now I think in high schools too, the teachers have to be sensitized. They have to be told, like we have been told that there's HIV tribunal. Not many people knows about tribunal, you see, and some of them suffers. We lost people every day because of stigmatization. Now I think sensitization will help, but again, the force of the government should come in, because some people are ignorant. You are being told that HIV does not kill. I am a beautiful story whereby I said that I got my child in Form 2. Now she's negative. She's 3 years old, going back to school. You see, and that's why I took part in talking to my community, because what I know is that HIV does not knock the door and tell the person, knock, knock, I'm coming, open for me. Sometimes even people get it at mysterious actions, like someone will just tell you, I just went for a test and I was told that I'm HIV positive. Now you want to discriminate the person, and even you are a person. So may think this conversation must go on daily for people to be sensitized and being told, and they must be told that if you discriminate someone living with HIV, you have to face your wrath and actions. And it is not easy thing because in Wajir County, the person doesn't have that information. Maybe the hospital is from here to town. The person is very sick, but due to stigmatization, he cannot go to the hospital. You see, when you reach the hospital, you tell, enter that room. People know that that room are for people living with HIV. Now you see these problems like stigmatization is a wide thing that I don't know how we should fight it.
It persists.
Yeah.
All right. Wex, you were going to speak about the importance of mentorship. If you had somebody talking to you, advising to you, a father, male figure in your life, advising you that you're still a young guy, tuliza boli kidogo.
Sawa. So mambo na mentorship ni kitu mzuri sana. Kwanza kwa vijana kama mimi, hata wengine wadogo. Sasa kama mimi ni artist, bado mimi hufunza watu hii kuchora. Bado after kuwafunza kuchora, bado mimi huwafunza mambo na mentorship, mambo na abstain sex, na baada kama ikiwezekana sana kutikiwa juu watumie CD. Mambo na mentorship imenisaidia. Kuna doc mwingine nilipata naye mrefu anaitwa Kolo, yeye amenisaidia. Kuna mwingine alikuwa anaitwa Ivan, amenisaidia. Hata Zipora hapa pia amenisaidia kwa mambo mingi sana. So mentorship ni kitu mzuri sana kwa vijana, mostly vijana kuanzia 20 kuendelea hadi teen hapo hivyo, au lazima tu ni mzuri sana kuwapatia mentorship. Yeah.
All right. Thanks for that, Wex. Prof, you know, as we conclude the conversation, what message would you like to leave us with?
I would say HIV is here with us. We have done a lot. There's been a lot of effort, as has been shared here, to improve on it. But we should not put our guards down. We should be alert. We should not discriminate against people with HIV. We should not unlawfully disclose people's HIV status. That's another area that the HIV tribunal addresses. And every effort should be made to ensure that people who are HIV positive live a normal, healthy life.
I'm curious, in a case like Zipora's, right, how do you balance her right to privacy and her right to health, healthcare? Because in school, she says she didn't take her ARVs because she was afraid of being stigmatized against, but it put her health at risk. How do you balance that? Because she was saying you should sensitize teachers, but you know, if her teacher doesn't know her status.
Yeah, so this is what you're talking about. The sensitization she's talking about is that the teachers, the headmistresses, the matrons within a hospital, in a boarding school situation, should be informed about the HIV, not to discriminate. It's actually brought us a lot as a result of ignorance. The fear that a HIV-positive child is going to transmit the infection to the other person. So in that situation of privacy, I bring Zipporah to school as a parent. I tell the headmistress, my daughter is HIV positive. This is the medicine she takes. The matron is aware. It is kept private. Nobody, the matron, the headmistress, the teachers do not disclose her status. We can have an arrangement that every time she passes to the matron's office and gets the medicine there. She doesn't have to keep the medicine for herself. Fear of that other students are going to see her ARVs, the matron can keep it. We have a schedule. Every morning as you go to class, you pass by, or every evening when you leave class, you come and get your medicine. The matron does not disclose. It's only the matron who knows her status. You're keeping her status private. You are saving her from stigma, other people seeing her taking drugs. That is the way to go.
All right. Dr. Masha, bring this conversation home for us. Your last word?
So just to say, as a country, we've made progress. And progress is not success. So what we are saying is that let's translate this progress into success by addressing the now gaps we've all spoken about. We celebrate success as a country. We've done it. But then we ask ourselves, how do we address the remaining and finally get to Victor's point, 2030, where we know all of us, if there's long-acting injectables that will be available for both ARVs as a treatment as well as for preventive medicine, or any technology comes out, we will not struggle to get everyone saying, let's come together, uptake the prevention service, uptake the new technology, and then we say, actually, we did it. Because this cannot be done by government alone, not by people living with HIV alone, but by every citizen, remembering it is a disease, it is a virus. It's not the person, it is a virus that is with us. Thank you.
All right, thank you so much to my panelists. I'm just looking at some of the comments online. Babu Michael says, I think the gains in the fight against HIV/AIDS could be made stronger in Kenya if we could introduce it into a syllabus like during our days. Most of us grew up knowing 1 or 2 things about HIV/AIDS. This could be the best approach. So the conversation continues ahead of World AIDS Day on Sunday. There is a half marathon planned. Where does it start, Dr. Masha?
Nyayo Stadium.
Nyayo Stadium.
Ends at Nyayo
Registration
Stadium.
is closed?
No, still ongoing.
Still ongoing. And where can people go to support?
The star hash. What?
I can check that for you. We will put it up on our social media platforms. And I thank my panelists this morning, beginning with Dr. Ruth Libon Masha, and she is the CEO of the National Syndemic Diseases Control Council. We've had in studio Professor Walter Joko, microbiology and tropical diseases expert. We've had from UNAIDS, the country director, Dr. Victor Bampoe. We've also had in studio Rita Gatonye, who is a harm reduction champion, Wesley Wex Otieno, who is a HIV champion, as well as Zipporah Acheng, teen mom and HIV champion. Thank you for having the courage to share your stories this morning. I'm sure it has helped many people. Thank you for sharing your expertise, the Dactaris and Professor this morning, and thank you for sharing your story as well. Rita, that concludes Daybreak. Do stay tuned for Level Up.